I'm Chris. Oh, thank you. So it's going to be recorded. Thank you. I'm Chris, Vice President of SFPM, and I'm in Seattle. And uh, it's a great pleasure to have Christian Regenbrecht from Berlin. Berlin, that's right.
Yep.
He's the founder of ASC Oncology GmbH, which is a functional precision medicine company. Just a brief introduction. He has a PhD from University of Bonn and has studied molecular genomics with Hans Leyrack at some point, and has extensive experience in startup world. So without that further ado, just take it over, please, Christian.
Thanks, Chris, for the kind introduction and the invitation today. Good morning, good afternoon, good evening from wherever you have tuned in. And I'm happy to share some of the things that we are doing at the company to advance precision medicine on this side of the pond. Let's see. The topics I will touch today is a brief company introduction, so I don't want to make it too much about the company, but more about the oncologist and patient landscape. Talk a little bit about the medical needs, the hurdles, the borders, precision oncology approaches, then how our reverse clinical engineering has clinical utility, and the design of a pilot study that we will hopefully soon start with the large university hospital here in Germany. And of course, afterwards, I'm looking forward to a fruitful discussion that brings us all a bit further. So briefly, who we are. The pun is intended that ASC Oncology is also the beginning of ASCO. So ASC is for Advanced Standard of Care, and we were founded in 2019 when I was still at the Charité University Hospital here in Berlin. Together with some colleagues, we thought it's time now to bring this into the market. And we have office and lab space at a campus in Berlin-Buch, which was the previous Academy of Sciences in the former GDR. So a historical campus where people like Max Delbrück have worked and did their research. Currently, we have 16 employees. Most of them hold a PhD or an MD. We have collaborations with various hospitals, not only in Germany, but also in Austria and Switzerland, and the King's College in London. And currently, we are working on bringing our technology to the Arab Peninsula, because there's also a big market of underserved patients that can benefit from precision oncology. With me, Quirin Graf Adelmann is the head of the company. We have totally different CVs. So I'm coming from the science sector, and he comes from the law perspective, which is very helpful in bringing precision oncology to the patient, in convincing or twisting the arm of insurance companies in paying for our services. And so this is a very, very fruitful duo in getting things in real life on the ground. We are smart, but we are not smart enough. So therefore, we have an advisory board with people like Angela Brandt, who holds a professorship for health genomics, Saskia Biskup, who is the founder of CGAT, a large sequencing company, Bettina Rill, known at least to the European participants in this call. She is in the ESMO patient advocacy group, and she brings in the patient perspective. And still, he is the head of the health services of the Public Bank of Berlin. So I said we were founded in 2019, as you can see here in the center, but this had already a prequel. The prequel was my academic life, where I was working in the Charité, and it was part of a large IMI initiative called OncoTrack. And in OncoTrack, the responsibility of my group was to build at least 30 patient-derived 3D cell culture models for the entire consortium. And after these 5 years of OncoTrack, we have had 80 models, and we still had some money over. So that was then the point where we said, okay, we are very effective in what we are doing. And so we founded in 2014 Selfinomics. Selfinomics is basically doing the same thing as AAC Oncology, but not for patients and oncologists, but for biotech and pharma companies. So we learned how to use the models and screen the models and deliver high quality data with our friends at the pharma companies. And then we thought, okay, we are now so good that new drugs came to the market after we served them in the preclinical field with very good predictions that we need to make a new company separately to show to the public that we do not mix up patient interest with those of the industry. And so in 2019, we founded AAC Oncology, and you can see here on the lower bar, all the time we were accompanied by EU or public funding to get better and better. This elder gentleman, James Watson, one of the big believers of genomics, once said, locating the genes that cause cancer has been remarkably unhelpful. The belief that sequencing your DNA is going to extend your life is a cruel illusion. That was in a New York Times interview in 2016. And who am I to oppose a Nobel laureate? So look at what the real world data says. Despite all claims from sequencing industry, it's a very small fraction of patients, I hope you see my mouse pointer, that really benefits from sequencing-based predictions of drugs that are administered. So we come up with a subgroup of patients that have targetable mutations. Some of those patients receive actually the matched drug, and only a fraction of them is benefiting. So that is the real world, real life as we experience it here every day on this side of the pond, not only in Germany, but Austria, Switzerland. It's always the same. It comes then that there is also only limited data available for rare and advanced diseases. So cohort studies are literally impossible or would take 10 to 20 years. And current studies show that it is a single digit percent amount of people that benefit from sequencing. In 2017, Amy Brooks has published a very, very good review called Precision Oncology Between Vaguely Right and Precisely Wrong. And I can only recommend to you reading this paper. I deliberately took one of the figures because it very well shows the problem. Our conception, or the conception of most of the people out there of cancer, is you have a normal cell, you have a mutation, and you have an altered genome or epigenome, and that fixes a phenotype. And if that was true, it would be very easy to identify, for example, with RAS, the mechanistic role in 2D cell lines, large screening, high throughput projects. And for that, it is easy to then identify a drug, make a so-called targeted drug. And in theory, this targeted drug should precisely aim with surgical precision these tumor cells and drive them into apoptosis. But the biological reality is much more vague. We now know that even within the same genomic background, the phenotype can switch. We have a dynamic phenotype that is plasticity, that at the same time, cells with the same background could be more sensitive or more resistant to a drug given, always with the same genomic background. Therefore, the prediction if a targeted therapy will work is rather vague. Of course, some of the cells would, as expected, undergo apoptosis. Other cells would survive and become, as they call them in the paper, stress-induced cancer stem cells, explaining why second and third line treatment are even worse for the patient. So the challenges we are facing today, beside ego and money, is that large clinical trials say nothing about the individual patient's response to therapy. Gene sequencing improves therapy for less than 10% of patients across all the indications. And so-called targeted therapies only work reliably for a few tumor types in many patients. So that are the hurdles, and that defines the medical need. We need some more precise instruments to see how to guide the treatment. So if you look at cohort studies, you very quickly find out that if you have unselected patient cohorts, as illustrated in the lower left corner, the average real-life data is not so much encouraging. But if you select, for example, for RAS wild-type patients, FOLFIRI plus bevacizumab or FOLFIRI plus cetuximab is much more effective as in an unsorted cohort. So, and what you also can see is that from therapy line to therapy line, the chances of a successful treatment is significantly decreasing. So the idea must be the right patient at the right time, as early as possible, receives the right treatment, whichever the right treatment is. Most people today, as I already said, understand personalized oncology as genomics, NGS sequencing, and so on. But we believe this is only a puzzle, a piece of the puzzle. And the entire puzzle is a combination of omics technologies and good cancer models. And therefore, we have a broader picture in interrogating this complex disease. So the technology advances enable our deeper insights into the individual tumor biology and all its heterogeneity. All of the technologies such as genomics, transcriptomics, proteomics just give a little glimpse on what makes up the tumor. And this makes it very difficult in a molecular tumor board to discuss this. And everybody who has been at a molecular tumor board knows, I think, the situation. You either come up with no actionable mutations and you're as smart as before, or you come up with 3 or 4 competing ideas and strategies. And I think functional precision medicine has a high value here to bring order into this and not make it like on a medieval market who is shouting the loudest will get the first try on the patient with his or her ideas. So that is where we see us and where we see our benefit. What we have depicted here is, let's say, a generic patient journey of grade 1 to 3 tumors. People come up with early detection. They feel somewhere a node in the breast, for example. They present with clinical symptoms. Sometimes in surgery, these tumors are found. We have in this phase neoadjuvant chemotherapy, later than adjuvant chemotherapy. And over the time, we find usually clinical recurrence. And this is just to illustrate to you that this patient journey is a long thing. It is also very individual. There's like a matrix that it follows, and this becomes of an interest later. So what we are doing is we are generating 3D cell cultures. We tend not to call them organoids because we don't use those protocols that have been established by the Dutch group. And to avoid misunderstandings, we call our cells PD3D cells, which serve as the same avatars as organoids do. So we can test the individual response of those cells for the patient in vitro. And we can then recommend the drug or the combination of drug with the prospects of the highest therapeutic success to the oncologist. How good are these models? So what you see here is in the upper panel, a colorectal cancer, original tissue, as it was stained by a pathologist. In the lower panel, you see the derived PD3D model from this donor tissue. And even not being a pathologist, you can easily see how similar those patterns are. In fact, these patterns are so similar, the biology is so similar, that we did a test with some pathologists at the Charité. We received 5 breast cancer tissues, made organoids from them, used our models, put them in FFPE blocks, sent them back, and the pathologist was able to match the right patient in a blind test with the right model. So well is the biology recapitulated. And another example of what I'm particularly proud of is the advances we made in the field of sarcoma research. So sarcoma soft tissue tumors are a little bit different to carcinomas. They don't have the usual suspect as driver mutations, and either you find only single mutation chromosomal aberrations, or the entire genome looks like it was treated with a shotgun. Long story short, we sent, I think it was 43 models to a pathologist, and she was able to also define the right subtype of sarcoma just from the model. And given that there are 120 subtypes defined by WHO, I think this is, from the perspective of a biologist, very good. You see this one outlier. I left it in for reasons of transparency. This basically, this angiosarcoma, the original pathology was done. Then the patient received multiple regimens of chemo, and then we received a piece of the tissue. And it is very, very likely that under the pressure of treatment, the original tumor has changed, and therefore our cells could not have been matched to the original tissue back again. But that is just so. For any organ or organ type cancer, the morphology of our PD3D models is different. So you see here some examples: melanoma, osteosarcoma, breast cancer tissue, colorectal cancer, non-small cell lung cancer. They look very distinctive there. And for each of those entities, we have different media conditions optimized for their growth, so that in average, it takes less than a month from receiving a biopsy to making a prediction for the clinician. So the workflow is quite easy. First, we consult with the patient if that procedure we offer is suitable. Then, and this I think is a very important step, we need to have the attending physician, the oncologist, on board. You cannot force them to do something they don't want to do. And maybe that will be questioned later in the discussion. So I already take it because I hear it quite often. Do we test things out of the box? Yes, we are capable of doing so, but it's also coming with an ethical response. Because what happens if we test something that is of benefit to the patient, but the oncologist is not willing to administer this to his patient? So then we are in an ethical dilemma. And therefore, this step of coordination with the physician is so important. Then we receive the sample, it gets shipped to us, we do the testing, create an individual report. And this report is not only sent to the physician, but also to the patient, as currently the patient is in Germany paying for this a priori. And then patient, oncologist, and we can sit together in tumor boards, decide and make a joint decision, which also shows that the adhesion of the patients to the treatment is much higher. So just another representation, what you see here, we do this part, consultation, shipment, and our treatment. But I want to stress how important it is that we have the medical team on board for selecting the drugs. The billing is run through the hospitals, the collection of the tissue sample, and the understanding discussion of the board is all part of the medical team. So we are all on the same boat, in the same boat with the patient to deliver. We'll just here quickly, these are our shipment boxes. So the doctors, as we work with various clinics and also small doctors' offices, even send samples from Australia to us. We have made these nice boxes with handling instructions and analysis form, so they can just tick the boxes what they want to have checked. So let's quickly jump over that. And the screening, that is maybe the interesting thing. We have established this assay together with colleagues from Eli and Lilly, and this holds up to the high standard of preclinical drug development in terms of batch-to-batch variation in terms of reproducibility, data robustness, and so on. And this has also been published in the NCI handbook for good practice approach of how screening these 3D cell culture models. So in brief, we disaggregate the organoids into single cells. We do it automatically with a robot. We seed it out in a 384-well plate. While the cells recover from the procedure, we prepare the drug plates with serial compound dilutions. Then we use the compound dilutions on the plate, and the readout basically is a cell titer glow, so ATP consumption. No magic, we just are very good at this one trick. What we are looking for is for drugs that hit the IC50 before they hit the maximum plasma concentration that is achievable in a human being. So here's just real-world examples, drug A and drug B. You could really exceed the concentrations, no response for the patient. Drug C, minor response in the range of a stable disease, but Folfox and cobimetinib both show very promising results. And by the way, the patient got it. I show you later in a patient case. And here, just as a control, you see nothing happens. That it's not just the ATP consumption that we are measuring is illustrated here. So we have colorectal cancer organoids treated with drugs that should work and that should not work. And you see here on the right side, the organoids are growing. On the left side, they, in the same time, undergo apoptosis. So it's something we can also prove in a time-lapse video. It's not just ATP consumption. So what do we deliver? We have the model, we do the screening, and then we deliver a report to the oncologist where we define the area under the curve and try to stick as closely as possible to something like the RECIST criteria. So to give them a brief overview. And what they find in the report, and you see this is German because we work mostly with German clinics, they get these graph bars. They get a table where we already pre-select what we suggest is a good in vitro response. They get the original data curves so they can look at them and get their own opinion. And this is basically what is the basis then for our advanced treatment decision. And therefore, we can, at all points where a patient presents in the clinic, apply our method and gain material. And the nice thing, I think, for clinicians in a hospital is that our entire pipeline does not hinder standard of care clinical pathology with all the histopathology, molecular pathology that is done. Then we meet at the interdisciplinary molecular tumor boards, discuss it face to face, and that I think is bringing really a benefit to the patient. We don't see what we are doing just as a lab service. So we invest heavily in a Europe-wide network of clinics and expert lectures. We use the social media channels for distributing knowledge. You find a lot of data on our internet page. We have a service phone for patients and relatives that is even opened on weekends because, you know, when you wait, or if you have an urgent question on your disease, you want to have it answered now and not next Monday in the business hours. So we also cooperate with non-profit associations that support us, and especially our patients. And currently we are planning also to have an online forum where we can moderate discussions between oncologists and patients. So the clinical benefit of what we are doing has been shown in multiple studies with 3D cell culture. So there is a meta-analysis of 17 co-clinical trials with various tumor entities. Diagnostic sensitivity was 81%, specificity 74%. Gastrointestinal tumors had a positive predictive value of 88% and a negative predictive value of almost 100%. And it has been shown that for people with lung cancer, the progression-free survival has been significantly increased from 9 months to 16 months. So I think the clinical data is there convincing the oncologists, but as so often, ego is in our way. Let me briefly talk you through two patient cases that I find very encouraging. This is the case of a relatively young lady, end of her 40s, two children, non-smoker. She was diagnosed with an appendix carcinoma with a high Ki-67 index of almost 70%. She had local disease, underwent chemo, went into remission, recurrence after almost 500 days. And at the same time, we got a sample, the NCT in Heidelberg, the National Center for Tumor Diseases in Heidelberg, got a sample for NGS, and another company got a sample for xenotransplantation. So to start with xenotransplantation, it took more than 400 days to establish the first passages, so that was out of range and out of scope for the patient. Sequencing took about 40 days, and wow, they found a KRAS mutation, yay, that was big. With our method, we delivered the drug screening of, I think, 18 drugs within 29 days. And then this went into the clinical advisory board, the molecular tumor board there. They decided to write an off-label application to the insurance company. They, of course, rejected it as usual in the first round. Then the patient wrote an objection. It was approved, and then the patient got what we suggested. And after 3 months already, the CT imaging showed a stable disease. After 6 months, the tumor was shrinking. So I think that is a very, very encouraging story. But the next story is even more dramatic. We received a piece of tumor from a patient with a CUP, a cancer of unknown primary. That was more or less exactly a year ago. It was the end of October 2022. The oncologist said, "You can do what you want. This patient will not survive Christmas." So we did our drug screening. We found, as you see here, in the group of drugs that we tested, some that were working well on the patient. So the patient got the drug. And I can report to you that this patient is back to work and back in her normal social life. As from the pattern of drugs the tumor was responsive to, the oncologist came to the idea, well, this looks like a breast cancer, a triple-negative breast cancer. So they did more rigorous screening of the breast and found the primary tumor. Then they could irradiate the primary tumor and do surgery on the primary tumor. And now the patient is cancer-free. As I said, she's back to work, and we are currently writing this story up as a case report for publication and as an abstract eventually for ASCO next year. So, and then what I promised you, we are doing clinical trials, and we have agreed with a comprehensive cancer center here in Germany about 3 different designs of a clinical trial, and a group of public insurance companies have volunteered to pay for that pilot study. So patient undergoes staging. We receive a part of the tissue. Tumor is sequenced. The organoids are sequenced. We treat them. We do the drug screening. Patient receives a neoadjuvant or palliative drug treatment. After given time, there will be restaging, eventually a rebiopsy. We have until then our drug sensitivity data and compare that with pathological response of the tumor in the patient. That is the primary endpoint of the study. And the secondary endpoint is progression-free survival, distance metastasis-free survival, and so on after 24 months. So what I like about this study design is that first results drop in after like about 6 months post-surgery, when the restaging is done. So this is, for example, a good study design, very conservative, so very, very low level also on the ethical side for rare cancers like, for example, sarcomas. Then the next study design that we would carry out with them is trying to bet against the number needed to treat. So the idea behind that is if you have indications with a bad NNT, then it is relatively low numbers where we can that we need to recruit to correctly predict it. So if we correctly predict that a patient will not benefit from that treatment, that is the one aim of the study. And the other aim of the study, of course, is that we correctly predict to which drug or which is the responder to the drug. And then we can have two arms on that. And last not least, the most thrilling study design that we try to carry out is an interventional single-arm open-label study. So basically, we recruit, we see if the inclusion criteria are fulfilled, we get the biopsy, we do our test, and the treatment is then according to the results of what we have tested. And the study objectives are then progression-free survival every 8 weeks after the first treatment course up to 2.5 years, quality of life, response rates, and so on. So these are the 3 things that we have agreed with real-life clinicians in a real-life setting. And we will hopefully start with these 3 studies by early next year to really show the clinical advancement. And what I'm very proud of is that there is a couple of insurance companies here in Germany paying for it as they see the benefit of what we aim to do. And so the benefit to them is not only cost saving, but it's the core elements, adjusted quality of life gained, net cost, but also common but inconsistently used elements like productivity. Can people go back to work? Adherence improving factors. So on the psychological level, then potentially new elements, reduction in the uncertainty, the insurance value can be increased, the value of hope, real option as a value. And what I, as a biologist, also like very much is the scientific spillover. So from what we have done in the past, we already have been granted an international patent for a MEK inhibitor, where we have screened like 80+ organoid models and found out a signature that allows a RAS-independent prediction of MEK inhibition or not. So to recapitulate, we can use it for all patients with solid tumors, carcinomas, sarcomas, metastases. We need a surgical specimen or a biopsy. And of course, the patient needs to have an indication where he undergoes drug therapy. We lately have published a paper that we can also predict now irradiation therapy together with some people at the Charité. Of course, it's not suitable for leukemias or lymphomas, where we don't have viable tissue or people don't get a drug therapy. What we can test currently is chemotherapy, small molecules, antibodies, and conjugates. What we currently explore in the lab is immune oncology with reconstituting autologous immune cells in the cell culture. This is something that we plan to be able to offer during the next 12 months. So the advantages for physicians: improved therapy planning, higher chances of an improved response, adherence can be increased, easy implementation in everyday practice. It requires little time from the oncologist, and it strengthens actually the patient-physician relationship because they have now more common grounds to discuss on. So we see this as a win-win-win situation, both for physicians, the patients, but also insurance companies. And last but not least, I always need to show this. This is not an animation. This is really a stop motion scanning electron microscopy movie of a colon organoid that we did together with a friend of mine. So thank you for your attendance, and thank you, the audience. And as you can imagine, all that would not have happened without a strong team. And I cannot mention everybody here, but I'm very, very thankful that I have such a dedicated team, from lab work to patient engagement to talking to the oncologist, but also people that help with all the communication stuff and get our message and the word spread. So thank you very much for your time, and I'm hoping that we have now some interesting discussion.
Yeah, thank you so much. That was everything and more, everything we like to hear. I have a couple chat questions, which the people who asked them are welcome to just unmute themselves, because we have plenty of time, and ask them themselves. So I'll let this, do people want to do that? If I don't hear a response, I'll ask the question, but I'll give people a second.
Yeah, I think it's Ines. I'm sorry, it's dark in here because it's night in Latvia. I actually wrote some of my questions in the chat, but I think I'll probably gonna write you an email, because this is one of the things that I'm trying to start, is like the functional precision medicine in Latvia, and I have some ideas, so I can contact you afterwards as well. But some questions. So first of all, what stage of the patients were used to take these biopsies from? Because when I talk to our medical oncologists, they are like, the ones they hear that they were going to have to biopsy the patient again, it's like, no, don't even think about it. So I wanted to ask, like, how do you overcome this one thing? And another thing, like, how do you overcome, because the thing that the clinicians are very used to the guidelines, and God forbid you go outside of the guidelines. So these are the two things that I wanted to hear how you get over, and also if your method is already approved by regulatory instances, because I think this is like the third stumble that I might have embraced talking with our medical oncologists in Latvia, that oh, it's not approved, so why do you even try? So thank you. Yeah.
Well, all of these are good questions I face day to day. I'm not sure if my wife has also tuned in. She's an oncologist. So if I say now I try to avoid speaking to oncologists, I deliberately exclude her. So the problem with the biopsy, yes, the oncologists are difficult. Therefore, we try to talk to the radiologists, the interventional radiologists. If they say that they're cool with it, then also the oncologists will follow. Second, we found that discussing specifically with surgeons, they're much more willing to support us. And also pathologists see this as fit. I have sometimes the gut feeling that at least some oncologists, as they have a picture in their mind of cell cultures being HeLa cells and not being relevant, and don't see the advancements that we did with the in vitro models, they are very skeptical. And yes, they like to stick to their guidelines. So what I tell patients actually is not, what do you recommend to me, oncologist, but to ask them, what would you do when you were in my position? Because what we found is that there are out some oncologists that recommend to their patients stick to the guideline for their own safety. But the very same oncologists, when members of their families or friends, close friends, had a cancer diagnosis, they approached us and said, could you do that to save my wife, my daughter, my son? So that's so irrational. And therefore I say, ask the people not what they recommend, but what would they do? And this is, I think, a very important point. And even in oncologists' families, there are cancer cases, and these oncologists suddenly open up very much to go the extra mile beyond the the guidelines. And from the legal perspective, guidelines are exactly that, what it said. It's a guideline. It's not a law. And interestingly, what we have already managed is that some hospitals and our doctors' offices like to work so much together with us that we could redirect patient streams from those oncologists that are naysayers to those oncologists that are supporting us. And as sad as it makes me, I think at the moment they see it in their purse that they get less money and less patients, and other people get more patients attracted with this kind of new technology, then they start rethinking it. So that's just my personal 2 cents on that. So the third question was?
About the regulatory things, like
Yeah.
the method is not approved by the EMA or whatever, like, are you using the hospital exemption or something? I don't know.
No, our lab that we have set up is accredited to ISO 17025. So we operate under the same basic principles and strict rules as a pathology would operate, for example. And that is more than enough to do that. But yeah, you're totally right. In some parts, one could consider any in vitro test in this field as a gray zone, which is in large areas not regulated yet. I think once this gains more traction throughout Europe, then the regulators will also step in, and then of course all the companies and service providers will have to adapt. Yet I'm very happy if we could discuss later then how we could eventually work closer together, because I think there's a lot of overlap and interest that are mutual to both of us. Then I see the question: what is an effectiveness in % to generate 3D models from patient material? Also a nice question. This depends on multiple factors. First of all, it's the quality of the sample that we receive. So if we receive just some fatty tissue plus necrosis, it's difficult to gain that. But for example, the sarcomas, we started with a growth rate or take rate of less than 10% in 2017, and now we are up to 75 to 80% take rate in cell culture for sarcomas. Same is true for colon cancer. The most difficult cancers, I have to admit, are those that are hormone dependent, because in principle you have to titrate hormone concentrations per every patient. So that are the most difficult ones, where we have the most respect and the least best growing curves. But with our biobank now having over 500 samples in there, we have some experience, and quite some experience with all kinds of entities. And if you're interested, as I said, we can have a one-on-one in the next week or so, and I show you a little bit about the data behind what we are doing.
Yeah, definitely. I think I'll find your email and so on. Thank you very much.
Yeah, it's easy. It's hello@asc-oncology.com.
Oh, yeah, that was in the first page. Yes, thank you.
Yes.
Yeah.
You're welcome.
Rajesh, do you want to ask your question? Or I can ask it for you. Rajesh asks, what's the timing of samples for the one from Australia in particular? How long in transit can these samples survive?
Yeah, Australia and also the US West Coast are challenges, not only because the discussions have a very come from different time zones, but the shipment took about 70 hours from surgery to our doorstep. And we had a discussion, how do we get this? And it's very easy. We used a hyperoxygenated media, or let's say solution, which is usually used for organ transplants to bring them from A to B, to make them survive. And so this was used for this long-term transport. and there was no significant reduction in viability of the cells as compared to all the shipments that we receive within 36 hours post-surgery. So that was really great, a good experience, and gave us the confidence that for few cases we can do it like this. If there would be a better stream in of patients from Australia, we would definitely set up a location somewhere closer to Australia.
Got it. Okay. Great. Okay, so I have a couple questions. What does your test cost?
So currently, the patient pay 5,700 euros, so roughly $6,000 for a test of 4 drugs, and then we top up 500 euro per additional test. We can, or I can report that we support then the patients with writing the reimbursement letters with the insurance companies, and the private insurance companies regularly pay for it, and about 65–70% also of the public insurance cases they pay for that, and so the patient are reimbursed. This is also the reason why the insurance companies want to negotiate with us now to bring it into the regular catalog of care to reduce the price, as it is then no longer for per patient basis.
That's amazing. That's really great. And your drug library, you said 4 drugs. Is that so? Do you have a standard drug library? And what does that look like?
No, so we have here in stock more than 150 drugs and compounds that we could test. Usually, for example, for the lady in Australia, we tested more than 50 drugs and combinations. So the 4 drugs that we test as our regular set is basically what we experienced, that this is what the oncologists are willing to try out in a case when they don't know us. They would go like, okay, these 3 drugs are somehow in the guidelines. That may be the second line or third line treatment, so let's add that. So we found that these conservative oncologists don't want a plethora of drugs tested. Eventually, it would, from our setup, be feasible. As I said, we work in the 384 format, to go with 20 drugs per plate and easily deliver that. And as I said, the ethical issue is then, what if we identify a drug that would work and the oncologist is not willing to administer it? That is a point. I don't have a solution for that. I would prefer rather having pre-set out template plates that have a plethora of drugs, and we do a shotgun screening basically, and deliver information to the oncologist. But I didn't crack the code yet how to crack this ethical issue.
Yeah, you have to ask Socrates that one, I guess.
Yep. Or ChatGPT.
Yeah. And have you had any success of drug combinations that ended up being given to the patient?
Yes. Just lately, we have identified a very potent triplet of drugs that is currently administered to the patient. But that was also one of the cases where basically the patient and the oncologist stood with the back to the wall. So that was last resort. And then also patients, they then want cowboys and not guideline people.
I see. Okay. Anybody else have any questions from the audience? I just have to say this is fantastic, and you hit all the high notes and all the low notes. The low notes being, the difficulties, the ego problem, the insurance problem, and we're all facing the same issues in this industry. But fantastic. Congratulations to your team and to the patients. I'm sure that's really rewarding beyond words, actually. So we'll get there eventually. And so again, to remind everyone, the SFPM is here for you. It's your organization. So please give us your ideas, how we can work together to overcome these problems and get these kind of tests to the patients.
Oh,
And I hope to see. Yes, go ahead. Someone wants to chime in, please.
I'm so sorry. It's me again. I'm so sorry. I still have like this one tiny question. You mentioned that the patients are asking for such tests and so on. How do you deliver? How do you make it so popular so that patients know about these? Because I think most of the patients have heard about the precision medicine, meaning like NGS. But what did you do in order to inform the society about these alternative tests? Sorry for extra question, but it's kind of important for us as well, I think, to inform the society.
Basically, it's very old school. I have an awesome communications department. So led by Melanie, we approach in a print media, many interviews. We were on local TV. She does a lot of work on social media with patient advocacy groups, trying to invite them, getting the word spread that we are out there. But this also sometimes makes it more difficult, because if you have a patient who knows more than the oncologist, then the ego problem kicks in again. So it's a very careful kind of communication that we use, but very effective in terms of patients. So my personal belief is, if we empower patients earlier, the sooner the better they can make really informed decisions about their lives and how they want to be treated. And if on the road we crack some egos of oncologists, I'm happy to do that.
Thank you very much.
So thank you, Melanie, if you're watching.
Okay, well, in lack of, thank you again, Christian. And I guess we'll sign off and see you guys all in a month or so when our next seminar series will be. And good night, everyone over there in Europe.
Thanks. Good night. Regards also to Anthony if you meet him.
Will do. I think he's traveling.
Okay. Take care. Bye-bye.
Bye-bye.
Thanks. It was a pleasure.
Yeah.